Regarding CA nasopharynx, we covered epidemiology, etiology, clinical features and different diagnostic modalities, and the remaining is on staging and treatment measures. So staging is important because depending on staging is the treatment. So there are mainly two streams or two systems of staging for CA nasopharynx. One is HU and another one is AJCC or UICC. So the HU staging modified in 1982 and AJCC bar UICC modified in 2002. So as far as publications and also other recommendations, the latest version of staging has to be used, and all publications prefer to use AJCC. And the main difference between AJCC and HO is based on the nodal status. So we can discuss about on this AJCC staging. That depends upon the primary tumor, regional lymph nodes and metastasis, distant metastasis. Okay, so primary tumor, regional lymph node and metastasis present or not. So what about the T staging? We can divide that into T X, that is the status of primary tumor cannot be assessed. T0, that is no evidence of primary tumor. Then comes TIS. What is that? Carcinoma in situ. Then comes T1. As in all other tumors, T1, 2, 3 and 4. Okay. T1 is primary tumor limited to the nasopharynx. T2, there is soft tissue extension. So again divided into T2A and T2B. So this division is based on the involvement of parapharyngeal space. So T2A is, there is no parapharyngeal space, but the tumor is extending into the nearby structures, that is oropharynx or into the nasal cavity. Okay. So oropharynx, extension to the oropharynx and or nasal cavity. But without parapharyngeal space involvement, and B is any tumor with the parapharyngeal space involvement. Space involvement. Okay. So T2 division to A and B is depending upon the parapharyngeal space involvement or not. And T3, so oropharynx and nasal cavity has already staged in T2, and what is remaining there? Bone is there and also paranasal sinus are there. So any tumor involving bony structures and or paranasal sinuses, that is T3. Okay. So involving the bone and or paranasal sinus is called T3, and T4 is intracranial extension. Okay. Intracranial extension and or what? Neighboring structures. What are the neighboring structures? One is, you know, it is orbit. So orbit. Then near to the orbit is infratemporal fossa. Okay. So infratemporal fossa. Then what? Going down. Oropharynx is already included in the T2A. So it is hypopharynx. Then orbit, infratemporal fossa, hypopharynx, masticator space. Okay. And along with the intracranial extension, what is also involved, that is a cranial nerves. Okay, so intracranial extension and or other 5 structures: orbit 1, infratemporal fossa 2, hypopharynx 3, masticated space, and 5th is a cranial nerve involvement. Then it becomes T4. So this is T staging according to AJCC. And what about this N staging? Again divided into N is presence of regional lymph nodes. Okay, so before N1 we have NX, that is cannot be assessed. The status of regional lymph node spread cannot be assessed like this. And N0, there is no evidence of regional lymph node spread. Then it is N1 to N3, N1, N2 and N3. N1 can be, N1 is unilateral metastasis, then 6 cm or less. It should be either 6 cm or less than 6 cm in greatest dimension, and it should be located above the supraclavicular fossa. Above supraclavicular fossa. Okay, so then it becomes N1, unilateral, 6 cm or less in greatest dimension and above the supraclavicular fossa. N2, this N staging is easy to remember. It depends upon the size and the supraclavicular fossa. So N1 is less than or equal to 6 cm in greatest dimension and above the supraclavicular fossa. N2 is above the supraclavicular fossa, less than or equal to 6 cm, but it becomes bilateral. Okay. And all the others are the same, that is equal to or less than 6 cm and above the supraclavicular fossa. N3 we have 2, that is N3A and N3B. So N3A is on the size, that is already equal to and less than 6 cm is included in N1 and N2. So N3A should be more than 6 cm in greatest dimension. And N3B, see, it is above the supraclavicular fossa in N1 and N2. So it should be in the supraclavicular fossa. Okay, so this is N staging. There is some difference in the N staging from other head and neck malignancies. Okay, so we have finished primary tumor and regional lymph nodes, and M is for metastasis, distant metastasis. There is MX, that is distant metastasis cannot be assessed, and then M0, no distant metastasis. M1 is distant metastasis. Distant metastasis present, no distant metastasis cannot be assessed. Okay, so this is AJCC staging modified in 2002 TNM, and depending on this we stage the disease also. So we can find out the stage grouping from this TNM stage. Stage 0 is it is up to this. Okay, so TIS, N0, M0. Carcinoma in situ, N0, M0 is stage 0, and stage 1 is again T1, N0, M0. Then stage 2 is divided into 2A and 2B. So stage 2A is, here see T2A, N0, M0. It's easy. T2A, N0, M0. And stage 2B. In stage 2B, this N staging changes. It becomes N1. So it can be of two types. One is if the T from T1 to T2A, N1, M0. So if T2A, N1 becomes T2B, or it can be T2B, N0 or N1, again M0. Okay, so that is also T2B. And in stage 3, this stage 3 is basically N2. Okay, here it becomes N2, M0. And what about here? So any from T1 to T2B become, and N3 become stage 3. So T1 to 2B. Along with that, T3 is also there. So T3, N0 to N2 and M0. It becomes stage 3. Okay, so T3, N0 to N2. So basically it is N2. Then stage 4. Stage 4 is again divided into A, B and C. Stage 4A, stage 4B and stage 4C. So stage 4A is stage 4A. N is again staging is up to N2, but here it becomes T4 and M0. Okay, so T4 with 2, 0, N0, N1 to 2 is become stage 4A, and stage 4B, the N staging changes to N3. Okay, so any both, either in more than 6 cm or in the supraclavicular fossa, that is N3, and any T here, and this is M0 again. And 4C, what is N4C? So any T, any N with distant metastasis, that become 4C. So any T, any N with a distant metastasis is stage 4C. So this is stage grouping of CA nasopharynx. This is very important. And also like other head and neck malignancies, the TNM staging in this CA nasopharynx doesn't need evaluation under general anesthesia. For all other head and neck malignancy, we have to palpate, or we have to see the clinical examination under general anesthesia will be needed. But this depends upon only the examination of the nasopharynx under microscope, then biopsy, and also the radiological imageology, that is basically CT scan and MRI scan. Depending upon that, we stage the disease. So that is the main difference between CA nasopharynx and other head and neck malignancies. Okay, I already told you that the treatment options depend upon the stage of disease. So this is the treatment plan in a nutshell. That is stage 1. It is the radiotherapy is the treatment of choice, and also for stage 2A, it is RT. So radiotherapy for stage 1 and stage 2A, and from stage 2B onwards, for stage 2B, 3 and all 4, that is radiotherapy along with concurrent chemoradiation, neoadjuvant chemotherapy and concurrent chemoradiation, or concurrent chemoradiation and adjuvant chemotherapy, or neoadjuvant chemotherapy followed by RT alone. But one thing you have to remember, that for stage 1 and stage 2A, the radiotherapy is the treatment of choice. And what we give is a mega voltage external radiation, that is external mega voltage external beam radiotherapy, ERT. We call it as ERT, mega voltage external beam radiotherapy, and the total dose should not exceed 65 Gray, and a single fraction should not exceed 2 Gray. Okay, so the total dose should not be less than 65 Gray, and in single dose should not, or a fraction should not exceed 2 Gray. And this is usually given between two lateral opposing shield and one anterior shield, so that the entire nasopharynx and also the lateral neck on both sides is covered. And if you suspect any occult neck node, or if there is a high incidence of occult neck nodes, then the elective irradiation of the neck is needed. And also if you want to give to extend into the parapharyngeal space. So posterolateral coverage can be included by giving a parapharyngeal boost radiation also. So that is external beam radiotherapy or ERT. And there are so many recent advances in radiation, mainly the IMRT, that is IM or brachytherapy or stereotactic radiotherapy. These are recent advances over this ERT. In brachytherapy, what we do is, can be of two types. Either we can implant, that is transpalatal implantation of radioactive gold grains, so that there will be a release of radioactivity, or we can into the cavity we can implant intracavitary after loading RT. Both are included under brachytherapy, and in this the dose can be reduced to 10 to 30 days. Okay, and if the tumor is too bulky or if it is near to some vital structures like an optic nerve, then this stereotactic radiotherapy can be tried. So all these can be asked as separate short notes along with recent advances for postgraduate residents. So be prepared with that. So this is regarding the radiation therapy for early tumor. The advanced cases we have seen at chemo radiation. So main chemotherapy agent is cisplatin, and this is and also 5-fluorouracil is also used as an chemotherapeutic agent. But cisplatin will cause bone marrow suppression, renal failure and sensory neural hearing loss. So patient should be under strict follow-up. And another drug which is under clinical trial is gemcitabine. This gemcitabine along with cisplatin is given for locoregional recurrence and in advanced cases. Nivolumab. This is a PD-1 inhibitor, that's a monoclonal antibody. This is given as an immunotherapy. So cisplatin, 5-fluorouracil, gemcitabine, and the latest one is nivolumab, which is used for immunotherapy as a PD-1 inhibitor. Emerging treatment modality is photodynamic therapy, and this is under trial, and it is in some centers worldwide. This is in the early phases. So photodynamic therapy, and the residents also should be prepared with a short note on photodynamic therapy. And what is the role of surgery in CA nasopharynx? So surgery is only for local and regional recurrence as a salvage therapy. So local recurrence means even after your radiation or chemo radiation, the primary tumor is recurring, or after controlling the primary tumor, the neck nodes are recurring. Then we have to go for a salvage therapy as and that is the only role of surgery in CA naso. So these are the treatment options: radiotherapy for early stages, then chemo-RT for advanced cases, and cisplatin, 5-FU, gemcitabine, and immunotherapy with nivolumab and photodynamic therapy. So these are the treatment options. And once again, I like to stress on the importance of early diagnosis in case of CA nasopharynx, because it is highly radiosensitive, and you can get almost 100% cure rate if you treat with radiotherapy in the early stages.